Okay, good afternoon, everyone. Thank you so much for joining us today. I'm Emily Finley, Program Coordinator at Community Campus Partnerships for Health, or CCPH. And today we have an amazing presentation about community-engaged approach to COVID-19 testing in African American churches. We have a fantastic roster of academic and faith leaders from Kansas City, Missouri, who will be sharing their work with us. And we'd like this event to be as participatory as possible despite our virtual constraints. So please feel free to use the chat box to introduce yourself, where you're located, and your organization or institution. And I invite you to use the chat box throughout to share your reactions and reflections to what you hear. And also, please use the Q&A box at the bottom of your Zoom screen to submit your questions for the panelists. We will have time later on in the webinar to answer some questions from the audience. Next slide, please. For those of you who are new to CCPH, we are an international membership organization, and our mission is to promote health equity and social justice through partnerships between communities and academic institutions. Since 2020, CCPH has really focused heavily on the response to COVID-19, particularly in light of all the inequities that have been exacerbated by the pandemic. CCPH is currently supporting 6 grant-funded COVID-19 partnership projects that extend across the country, including the North Carolina Community Engagement Alliance Research Team, or NCCEAL, and the NICE project, which is focused on COVID adult vaccine equity. And in the midst of all of this, we're also celebrating our 25th anniversary this year. So stay tuned for more events throughout the year. You can check them out on our website or sign up for our newsletter to hear more. Next slide, please. And CCPH provides training, consultation, and technical assistance to both community and institutional partners with the goal of strengthening community engagement and building authentic partnerships. Whether you're a community leader, an academic, or a student, we would love to connect with you. Please, again, visit our website or look us up on social media. We're on LinkedIn, Facebook, and Twitter. Next slide, please. CCPH is proud to support the Rapid Acceleration of Diagnostics Underserved Populations Project, or RADx-UP. We do this in partnership with Duke Clinical Research Institute and the University of North Carolina Center for Health Equity Research. RADx-UP aims to ensure that all Americans have access to COVID-19 testing with a focus on communities most affected by the pandemic. So there are currently over 100 RADx-UP project sites across the country. If you're affiliated with one of those projects, welcome. We're so glad to see you here. And CCPH provides community engagement support to the RADx-UP network through our office hours consultative service, through trainings and other initiatives. Next slide, please. So before we begin, I'd like to take a moment to acknowledge and honor Black History Month. This is a time to remember and reflect on the achievements and legacy of Black individuals and communities who have made indelible contributions and sacrifices for the betterment of humanity. We continue to see social inequities and injustices impacting our Black and African American communities, and systemic racism has contributed to the disproportionate suffering and death of Black communities from COVID-19. The theme for Black History Month in 2022 focuses on the importance of Black health and wellness. So we're especially honored to hear from our distinguished Black colleagues today who are leading the fight against COVID-19. Next slide, please. So during our 90 minutes together today, we're going to explore a faith-based community academic partnership grounded in community-based participatory research, and discuss the roles that community organizations and leaders can play in health equity research. Next slide, please. All right, on to our speakers. We are so glad to welcome Dr. Jeanette Berkeley-Patton, professor at University of Missouri, Kansas City School of Medicine. She is also the director of both the UMKC Health Research Group and the UMKC Health Equity Institute. Dr. Berkeley Patton is principal investigator on the study exploring COVID-19 testing and linkage to care with African American church partners that we're going to be learning about today. And also from UMKC, we welcome Carol Bowe Thompson, project director of the UMKC Community Health Research Group and director of the KC Faith Initiative. Both Jeanette and Carol bring a wealth of experience in community engaged health equity programs and research. Next slide, please. We also welcome two incredible faith leaders from Kansas City who are working on the front lines in the fight against COVID-19. Reverend Eric Williams serves as pastor at Calvary Temple Baptist Church, and he's also the founder and executive director of the Calvary Community Outreach Network. And finally, he's joined by the Reverend Dr. Faith Allen, who is a pastor at Jameson Memorial Temple CME Church. So welcome to our four wonderful speakers. Next slide, please. So I know that we all are eager to hear from our presenters, but first we have a very special treat for you all. We're going to share a short film about the project that was produced by the communications team at UMKC, and this will give us a really nice introduction to the project. It's called A Faithful Response to COVID-19.
With the African American faith community in the greater Kansas City, Missouri area. Our churches are located in some of the most underserved areas of Kansas City and certainly would fall on the index as being socially vulnerable communities. For the most part in the Kansas City area, we are still kind of riding the top of the Bible Belt. So everybody goes to church here, especially if you're African American. We lost a couple of pastors who got COVID-19, passed away, and many other pastors were sick and some were hospitalized. But because of that, it really brought attention to the fact that the faith community really needed to position itself to be an early responder for this pandemic.
My role would be managing the faith partners that are involved in the process, in the program. It is being able to recruit, train, mobilize, sensitize people to the need. Arming faith-based institutions with the information that they need to preach from their pulpits. We want to make sure that they have accurate information and that they use their powerful voices to build trust, to build a sense of community from pastors and congregations that are involved. Our journey through this process really started over 20 years ago. And it started with another pandemic. You remember the little pandemic called HIV and AIDS? We wanted to prove that the inroads that we were making with our churches, the congregations, that they were working. We knew that compassionate care, we knew that the trust that pastors have with their congregations, we felt like it worked, but we wanted to know that that evidence-based practices were being used. Enter UMKC, enter Dr. Jeanette Berkeley Patton. It was her job to help us prove it.
Because our research team is steeped in community-based participatory research, which is an approach to research where the community members are fully engaged in every single phase of the research study. We were able to work with them to get their input on, what are the key ways that we can distribute messaging through churches now that we're in a pandemic. How are churches gathering? How are they reaching out to their members? How are they reaching out in new ways to their community members?
The Kansas City community is very diverse. It is a beautiful town, beautiful space. However, there's still pockets in our community that And in those pockets, particularly the east side, you know, we struggle with every malady that you can think of. We're leading the list in all the wrong areas: heart disease, stroke, diabetes, blood pressure, HIV, and COVID as well. And COVID really helped us uncover a lot of things. It was the perfect storm of fatal activity with Black Lives Matter movement and George Floyd, and just everything happened at the same time. If we don't get the health space correct, then heaven's going to come much too soon for some people. And I'm always the one that ends up doing the funerals. I don't like funerals. I like to see healthy people, healthy families, healthy congregations. And so it's particularly important for me is because we can save lives through the strong stance of churches, through pulpits across America.
Our faithful response intervention is unique because it is culturally and religiously tailored for the African-American church context. So we like to say that if it happens in church, we have a tool for it. So we've created, in collaboration with our faith leaders, a comprehensive toolkit that includes everything from sermon guides, responsive readings, church bulletins, Bible bookmarks, testimonials from people who have received COVID-19 testing. For us, one of the things that we had to do was to pivot not only how we adapted the tools to be delivered virtually or digitally, but also even in our data collection. So we had to really adapt to figure out, okay, how are we going to enroll people virtually? How can we survey people online?
The project helps us first to communicate and build trust within the research framework. I think largely because of our success with projects like this, we had an opportunity to collaborate to do a vaccination project that was largely on the east side. And so we were able to recruit 20 churches, 15 neighborhood organizations, 15 area businesses to work in the space together to bring vaccinations to the east side. These activities stay here. The relationships that we build with other faith-based institutions, other medical institutions, and other research institutions begin to serve as a model for next steps. What we do here will translate into the next issue, the next problem, the next pandemic, the next health issue that we have to deal with. Our politicians are listening. And so if we can keep it together, if we can do this right, then we also have an opportunity to change policies that are connected with health disparities.
Fantastic. Thank you so much. It's a really, really powerful video. We're going to transition now to a presentation from our panelists so that we can learn more about that project. Here we go.
Sorry, 1 second, sorry.
No worries. Give me your reactions to the video. What did people think? feel free to go in the chat and tell us your reactions. Amazing, very powerful. Yeah, thank you. All right, well, we can move to the next slide. All right, awesome. And I will let the panelists take it away from here.
Thank you. Hey, everyone. I'm Jeanette Berkeley-Patton, and I'm just delighted that we have this opportunity to share what we're learning in increasing access to COVID-19 testing with African-American churches in Kansas City. I do want to give a great thank you and shout out to CCPH for providing us with this opportunity, and also to the rest of the RADx team. Our project number is Project 44. Again, it's located in Kansas City. And the name of our project, which was actually named by our faith leaders, is A Faithful Response to COVID-19. Next slide. Just as a quick overview for what we'll share with you today, I'll start out with a project description. I'll share our specific aims, some of our research design, along with some of our early findings, baseline findings from our first wave of our study. And then I'll be followed by Reverend Eric Williams, who will talk about our faith health academic partnerships, including the call to action with faith leaders to address COVID-19 or the burden of COVID-19 with our African-American community in Kansas City. Carol will come on and talk about CBPR principles. She'll give an overview of the CBPR approach that we use in Kansas City, along with how we engage our faith leaders in designing and implementing our intervention. And then she'll wrap up with some of the dissemination strategies that we use to share what we're finding with our larger community. And then we'll have Dr. Reverend Faith Allen come on, and she'll talk about her experience as a church health liaison and implementing the project at her church. And then I'll be back to talk about sustainability of the project. And then we'll wrap up with Reverend Eric Williams discussing some of the emerging needs that we see in Kansas City. So we look forward to your comments and your questions in the chat as we progress through this presentation. Next slide. Just to start with specific aims, I do want to kind of lay the context that our research team, the Community Health Research Group, has been working with our faith community now for almost a decade and a half. We've worked with over 50, it's probably over 60 churches throughout the Kansas City urban area during that time frame. And we've worked very closely with Reverend Eric Williams and Calvary Community Outreach Network on all of the faith-based intervention studies that we've conducted. And so with this particular project, we wanted to expand on that work and expand on partnering with African-American faith-based organizations, along with our health department, the Kansas City, Missouri Health Department, who's also been a long-term partner with us in our early days working on HIV testing in African-American churches, and now doing the COVID-19 testing with our participating churches. We also aim to test our culturally and religiously tailored multi-level intervention that's really built off of the model that we've used in past health screening interventions with churches. And we want to test that against a non-tailored or a standard intervention approach and see if we can improve rates of COVID-19 testing with our intervention. And then we want to be able to understand factors and strategies associated with receipt of COVID-19 testing, along with conducting a process evaluation where we're trying to understand some of the facilitators and barriers that contribute to whether or not a person gets tested at church or anywhere else. Next slide. I always like to start these presentations with, why are we doing this work with African-American churches? Well, you know, our African-American churches have so many incredible strengths. We know that they have diverse memberships, where there's everyone from the babies of the church to the elders of the church sitting in the pews, from the poorest of the poor to the richest of the rich. We know that for many of our churches, they have very similar biblical beliefs and activities. There's rarely an African-American church that, at least for me, that I can go into this country where I don't know the songs, you don't know the process, you know the vibe, you know the flow. And so those are strengths that, along with having multi-levels of contact, including ministry groups, church services, outreach ministries to reach out to the larger community, and a tremendous amount of influence on health behaviors and social support through the networks that are naturally built in churches. And then also, click please, also we know, and this is what really gets me excited, that on any given Sunday, about 50% of African Americans in this church is attending someone's service. So if there's ever an opportunity to get to an audience of African Americans and to disseminate health messages, the church definitely is one of those places that we want to be. And then lastly, click please, because we know that there are so many churches in our urban communities and in many rural communities. So that allows us to really think about how can we take these interventions like our COVID-19 intervention to scale, and also how can we build these interventions so that they fit within the natural infrastructure of churches so that we can sustain them over time. Next. So I just want to give you an overview of our faith, community, health, and academic partners. We have 17 churches involved in our study. I do have to say again, because of our long-term relationship with our churches, we were able to quickly recruit 17 churches. One of these churches was a pilot church. We did a small pilot study within about 3 to 4 months after we seeded the grant last year, January 2021. It feels like last week because it's been a fast ride. And then the other 16 churches are a part of our clinical trial. And they are, again, in some of the most socially underserved areas in Kansas City, in urban Kansas City. We also have as a partner our Kansas City, Missouri Health Department. Again, they've been a long-term partner of ours. They've worked with us from the very beginning in the planning of the intervention and planning how testing was going to be delivered, how results were going to be delivered, and helping to develop an online platform for registration and for the collection of other information from our participants. And then we have partners in the faith community that go beyond just our churches, but also organizations like Calvary Community Outreach Network that, again, we've partnered with for over 15 years, with our KC Faith Initiative Community Action Board that's been established for the last 10 years, and then more recently with the Clergy Response Network, which was developed early on in the start of the pandemic by Reverend Williams to really address the unmet needs that were being seen in the African-American community in Kansas City. And then we have researchers from across the country from 7 other academic institutions that serve as co-investigators on this project. Next slide, please. So just to give you an overview of our faithful response approach, for our research design, again, we have a clustered randomized trial with 16 churches. Our target recruitment goal is 960 congregants and the community members that they serve. In fact, we are attempting to recruit 60 participants from per church, 45 of those church members, 15 of those being community members who use church outreach services like food pantries, clothing pantries, after-school programs, social services. And so they're frequent users, are frequently affiliated with those churches. Our 16 churches are divided into 2 waves. Each wave has 8 churches, and they're randomized to either receive our religiously tailored faithful response intervention or a standard non-tailored information intervention. As far as our CBPR and COVID-19 testing intervention, at the foundation of this project for our faithful response intervention is a toolkit. And Carol will talk about that toolkit in a little bit more detail when she comes up. But with that toolkit, we really are trying to equip our faith leaders to be able to talk about COVID-19, to motivate COVID-19 testing, and to work directly with our health department in those efforts. Each church has the COVID-19 testing events taking place at their church. And then along with that, and working with our Kansas City, Missouri Health Department, we also have contact tracing and linkage to care services that are being delivered with a motivational interviewing kind of light approach to really improve or enhance the communication skills and the motivation for folks to follow through with contact tracing and use of the linkage to care services. And then as far as our data collection, we have a self-report baseline and 4-month survey that's being administered with our participants. They can complete that survey online and in person. In person, we use electronic tablets as much as we can, but we do have some people who just refuse to use them. And so we also have paper copy surveys in some cases as well. We also receive our COVID-19, our objective data from the Kansas City, Missouri Health Department via a data sharing agreement. And then lastly, again, we're conducting a process evaluation that includes direct observation of what's happening in churches. Our team goes out on Sunday, during the Sunday services when the COVID-19 testing events are taking place. They observe the church service, they observe the COVID-19 testing events that take place in the fellowship halls and in the parking lots. And then we also have our church health liaisons that are trained to implement the project, providing us with monthly implementation data on how they're implementing the project, what types of tools they're using, and who's the audience and other information. Next slide. So I just want to give you just a first look at our baseline data with our wave 1 churches. As I mentioned earlier, we have 8 churches in wave 1. For wave 1, we've recruited 405 participants. So didn't quite meet our goal of 480 participants, but we're quite certain that we'll be able to make it up in wave 2 with our other 8 churches. And for our baseline characteristics, you can see that we have really good representation across the age spectrum, and that our average age of participants is about 50 years old. We have an incredibly high proportion of females in our study. This is something that we've seen in all of our past church-based studies. However, I do have to say that at 75% for females, this is a little bit higher than what we've seen in past studies, which tends to be more like about 65 to 66%. Most of our participants have insurance and have a high school education or higher, but we can see that during the pandemic that a good proportion of our participants lost their job or income due to COVID-19. That's about at 30%, along with our experiencing food insecurity, again, about 30% of our wave 1 participants. As far as comorbidities, we see about 60% of our participants reported that they were living with some type of chronic health condition. And that condition with the highest response was hypertension. You can see that about a little over 40% of our participants reported that they had been diagnosed with hypertension. As far as reporting that they had been tested positive for COVID-19, we had about nearly 20% of our respondents reported that they had, and this is about in line with what we see nationally in the United States as far as the percentage testing positive for COVID-19. And then lastly, what you see is that a little over 60% reported that they had received a COVID-19 test in the past year. So that's where we are right now with our baseline findings. We look forward to sharing more information, especially once we get our next 8 churches through wave 2. And with that, I will turn it over to Reverend Eric Williams.
Thank you, Dr. Jeanette. Hopefully I can be heard. Can you hear me? Good. good. And thanks to each of you who are doing what you can all across the states to make sure that people are safe. It's just a beautiful thing to know that folks are concerned, that folks are active, and that we're not sitting back silently and allowing things to happen to us. But there are folks like you who are arming and helping our communities. Dr. Patton talked a lot about history. She said 15. I thought it was more like 20 years. I thought it was more like, seems like she's been a friend for a long time. And friendship and partnerships are similar. When we initially met, it was because of that other pandemic. You remember the one that stigmatized our loved ones, the one that caused so much fear amongst us. Remember the one that everybody was ignoring, and they were calling it sin and all kind of other things. It was in that atmosphere that we met Dr. Patton, and she helped us to make sure that we could end some of those things, the stigma, the fear, the misinformation. She helped us to prove that caring for people really worked, that speaking truth to power from pulpits really do work. And the framework was just beautiful. Partnership, friendship. This is for all of the researchers that are listening. I think our relationship goes far beyond the numbers. It goes far beyond the research paper. Dr. Patton attended my dad's funeral. She's hung out with us in some of the desperate times. She's been there to celebrate. She's been there to cry, and it's just not another practicum experience. It's just not another thing to put on the Vita or the curriculum. It's being there. It's caring about the community that we serve. It's bringing to bear everything you know how to do as a researcher or a preacher or just someone who's concerned about life. One thing I will share is that, we pretend that she's nice and all that, but she forced us to do this thing called the IRB test. And over and over and over again, she forced us to read this stuff, the IRB this. I'm like, why we got to do? She says, well, it's what we need to do to make sure that things are above board. And it comes in handy because it helped me to understand as a pastor that, yeah, there are some rules that researchers have to follow. There are some rules about human subjects. So when this vaccine starts coming and everybody is up in arms about should we trust it or not, I understand now that there are processes in place that scientists and researchers have to stick to before they can just willy-nilly give a vaccine. Thank God for Dr. Patton. The history is really very relevant. We've done a lot together, and I thank God for that. One thing that was always said in the early days was, "Where's the church? Where's the church?" And with HIV specifically, the churches were slow to move. And it always reminded me of the text where the guy named Lazarus had died and Jesus waited too long before he came. And when he got to the scene, the two sisters said to him, Jesus, if you had been there, my brother wouldn't have died. And that really resonated with me because it's almost as though they were accusing him of not caring. And it's that same feeling that pastors and churches have to have as we see our loved ones passing away. And someone says, Pastor, if you had been here, my brother wouldn't have died of AIDS. Pastor, if you had been here. And I didn't want that same thing to happen with COVID. Church, if you had been here, so many people wouldn't have died. And so the photograph that you're looking at now is just a few of our colleagues handing out masks so that, you remember in the early days of the pandemic, we didn't know whether we should go to church or not. We didn't know how to gather. We didn't know what to do. We were all afraid, and we were able to distribute over 80,000 face masks so that the people that were going to be participating in live or in-person worship, they would at least be armed. This was even before the vaccine had come. Early in the pandemic, we said, we've got to do something special. We've got to drop our denominations, drop color, drop whether you're Baptist or Islamic or Presbyterian or Catholic. We have to come together and do this. So we formed what we called the Clergy Response Network so that we could begin the discussion, so that we could share with people how to be safe, so that we can get resources into people's hands. And over the years, Dr. Patton and her staff over at UMKC have helped us to gain the trust of pastors and congregations all around the Kansas City area. It's a thing where they know that they can trust us with the correct information and help their congregations live. Next slide. This was one of the events that we had during the pandemic. I think this was pop-up food. We wanted to serve the community, and we continue to do that now. In our early discussions, and Dr. Patton has this thing about whiteboarding, and she just dreams up stuff. We just sit around talk, and we dream up stuff. She puts it on the whiteboard, plots it out, and somehow the name first responders came. And typically, when you hear that, you think of like in New York, the firefighters that climbed up those towers, and they were the first responder. They were, but in this sense, we wanted to see pastors and congregations as first responders. We see things sometimes that the others don't see. We get the opportunity to be there at births and at deaths and at graduations, at celebrations, and why not use the strong stances of the churches to arm folks and to help them to survive. I think I better pause there because I think there are time limits, and I start preaching sometimes and it doesn't work. So, but before I stop, notice at Kansas City, I didn't see any Cincinnati people, but I hope that you're fighting a good fight in Cincinnati too. Bless you.
Well, that's a tough act to follow, Reverend Williams. But I'm happy to be here. And before I dive, if we can advance it forward. Before I dive in and discuss how we engage our community partners in the research process, let's quickly just talk about a few of the reasons why we use community-based participatory research approach. We know there's a growing recognition that traditional research approaches have failed to solve complex health disparities. And community members are very wary of being, what we call guinea pigs, where research is done on their community and not with our community. And there's an increasing demand that research address their locally identified needs. So traditional researchers often complain. Biggest complaint, the challenges to recruiting research subjects. And let's be real here. These challenges are often a result of our community members feeling that researchers have used them and taken the data or findings away from the research, away from them, and to benefit just the researchers alone. Big example would be our scholarly papers, right? We take all that data, put it in a scholarly paper, but do we share that information with the community? So the community feels left out with no direct benefit or feeling that the data or the findings belong to them as well. And so if we really think about it, significant community involvement can lead to scientifically sound research. Researchers using participatory methods like us have found community input invaluable in the design and adaptation of research instruments to make tools educational materials more user-friendly, applicable, and also culturally and religiously appropriate. So research findings can be applied directly to develop interventions specific for communities. The specific outcome of CBPR research is not simply to find answers to complex social questions, but to have those results provide information that can be used by the community to develop its own solutions as well. So it doesn't belong just to us as the researchers, it also belongs to the community. So CBPR does have the potential to build greater trust and respect between researchers and community. Trust and respect are two common reasons why individuals and communities do not participate in research. If we actively, kind of like what Reverend Williams was saying, right? So if we actively engage community members and church members in an equitable manner, trust is more likely to be built. And I think Reverend Williams really brought that point forward as he was talking about Jeanette and her inroads in the community and how we as a group, as a research group, really do. We go to our churches on a Sunday morning and we're sitting in the pews now and we're clapping our hands and we're singing the songs and we're making sure that we wear our t-shirts so they know that we're representing the research group, but also that we're there and we're fully engaged. So with those points made, let's move quickly through how we engage our community action boards across the research projects, across our research process. As agenda setters, we work in collaboration with the community to agree on a research question to figure out what is it that we want to learn. As intervention developers, we take a considerable amount of time identifying at least 3 major items during this development phase. 1, important and feasible strategies for project implementation, like should we weave in educational sessions as part of the intervention? We look to the community to answer that question, our community action board as their representatives. This way, we ensure that all of the strategies in the intervention align with what the community would consider doable and significant to the intervention design. The other item is asset mapping, or identifying existing community resources as potential partners that can support project implementation during the research phase and potentially afterwards as well. And we'll talk about that. And Jeanette will talk about that sustainability also in the as we move forward in the presentation. And 3, developing culturally and religiously tailored educational and promotional materials, building what we call a toolkit for dissemination through the intervention and implementation phase. As intervention implementers, the same members of the Community Action Board developing the intervention become partners and collaborators in implementing the intervention at their respective churches or community-based organizations. And we'll hear a little bit more about that from Dr. Reverend Faith Allen, who's on our panel as well. And as evaluators, the partnering organizations are asked to track and report on their implementation activities through an online system. and that weaves them in as project evaluators. In addition, we share data reports and successes and challenges on project implementation that gives us a chance to get real-time feedback from our community partners to help enhance the delivery of the intervention along the way. Then, finally, as disseminators, well, not finally, then as disseminators of the work accomplished, we work alongside our CAB members to interpret the data that we've collected together and build community feedback reports that we share at community forums. And I'll talk about that too in a little bit more detail here soon. We also actively engage our partners in presentations, just like we're doing today with Dr. Faith Allen, Reverend Williams, myself, and Jeanette, where the project information is shared, not only from our point of view as researchers, but also including their perspectives. It's very important. Finally, and importantly, we keep our eye on the prize of impact and sustainability. The work we do, oh, and can you click for me for that? Thank you. Finally, we keep our eye on the prize of impact and sustainability. The work we do needs to live beyond the research phase, or why do it? So to the point of using existing community assets that will be around long after the research phase is completed, along with training our partners on how to deliver the intervention beyond the research phase without those big research dollars, that's always integrated into our trainings and across the whole process. So keeping our eyes on that prize of impact and sustainability is very important along the process. And advance, please. So now let's quickly talk about how we implement our faithful response study. First, we train our faith leaders, including our pastors and our church health liaisons, to deliver the culturally and religiously tailored toolkit materials and activities. These materials are disseminated to the church community members by the church health liaisons and pastors, either one-to-one during conversations, at small group ministry meetings, during Sunday morning sermons or services where the pastors will preach sermons about a specific message that motivates congregants to learn their COVID-19 status. And finally, we like to share those tools with our community members that receive outreach support from the churches through events like food pantries, daycare, daily daycare activities, health fairs, and also special concerts. So wherever there's an opportunity to disseminate a tool through the church and how the church works, those tools are developed to be specifically woven into the fabric of how the church does its work. And this way, we're not asking the church to do any more than they already do. Finally, our partners at the Kansas City Health Department collaborate with all study sites to provide, and the church health liaisons at those study sites, to provide 2 COVID-19 testing events, where they will also interact with contact tracers at these events as a way to establish relationships and hopefully have better uptake on engaging with contact tracers if they test positive. Then, if safety net resources are needed, like finding a primary care provider, or even getting a resource on how to pay their mortgage or their rent during their time living with being COVID positive, those contact tracers will be able to link them with a community health worker to provide that support. And let's advance. So, what are the roles of our church health liaisons in the implementation of the intervention? We call them CHLs. They deliver at least 2 to 3 toolkit materials per month. They coordinate 2 testing events, and the pastors encourage everyone to learn their status during Sunday morning services. They also attend quarterly booster meetings to discuss the success, challenges, and share those success and challenges with the other churches within their study arm. And we can actually take that time to figure out what project changes are needed, and actually take time to put that into effect as the intervention is being delivered. All right, let's advance again. So what do some of our religiously and culturally tailored tools look like? So what you're seeing here, let me open my slide up a little bit, are just pictures of a sermon guide, a responsive reading, and our text messages. And we have a full toolkit. Like you heard Jeanette say in the video we watched earlier, if it happens in church, we have a tool for it. And you can see that the list on the slide includes coordination of church-based COVID-19 testing events, a pastoral sermon and comment guides, responsive readings and testimonials. But the one that I want to mention most is our tailored text messages. It was the most fun to develop with our Community Action Board, with CRN. And we used input from our children as well, and others in that group. So it was lots of fun to develop those text messages, and then to contract with our tech partners at Agile Health to utilize their platform to deliver and disseminate those daily text messages that include links to resources and that motivate participants to learn their status. So the picture you're seeing here kind of gives you a really good view of what those text messages look like and what they read. And you can see that in one of them, it gives information and resource that circles back to one of our main partners at the Kansas City, Missouri Health Department, where they can call that number and get tested, even outside of the testing activities that we offer at our sites. Okay, let's advance forward. And this basically is just giving you a very good look at our responsive reading tools, a testimonial tool, where we talk about how to overcome the fear of COVID-19 testing. And so those role model stories that you're looking at, we have one for a man and one for a woman. And it's just a story that you share. So, you know, like a testimony at the end of church. I think Rev takes time to hold the mic so that folks don't talk too much during that testimonial time. But utilizing this tool, he doesn't have to hold the mic too long. People are able to share this story one-on-one with each other. I see you laughing over there, Rev, so you know what I'm talking about. So let's advance to the next slide. So project dissemination. This is like the most important part because, again, going back to that point of our community feeling like they're being researched on instead of the research also belonging to them, right? The outcome of those research and that data from the research. So when we're looking at dissemination, it becomes one of the most important components of what we do to utilize our relationship with our community action boards and those meetings that we have on an ongoing basis to review all of those findings, come up with an opportunity to come up with the plans on developing a community forum and our opportunity to share this information with the community. And so that's what we do. We offer community forums at least at the end of each intervention or even in the midst of the intervention to get even more feedback from our community, right? And we do this community forum at a shared, a well-known community venue here in Kansas City, whether that's at a church, whether that's at a conference center that everyone is comfortable coming to. But we make it very accessible to our community. And as you can see from the pictures here, sometimes we got to be really creative about that. So we have our meetings with our Community Action Board virtually during COVID, and we will be doing our community forums also hybrid, virtual and in person, because we know that we want to meet and reach the community to get them this information. We also use shared media platforms. We have websites, we have Twitter accounts, we've got Facebook accounts. So we get that message out there any way possible for those community partners to come and learn, and we can share the information that we've learned. And of course, that last bullet there, shared presentations and publications. I don't know any time that Jeanette and I have put together a manuscript that involves the work that we've done in the community and have not listed, and shared authorship with our community partners. And I have to say, we send those manuscripts out and we get great feedback from all of our community partners. And so they have a say-so, a real say-so in the development of those manuscripts. And so with that, I think I can wrap up and we can advance on. And this is, oh, well, let me just pass it on to Dr. Reverend Faith Allen to tell us about her experience as a pastor and a church health liaison implementing faithful response at her church. Dr. Allen.
Okay, thank you. Thank you, Carol. And first of all, I just want to say, of course, all of this could not have been made possible with our being able to implement this without the relationship that we have with you, with Dr. Jeanette, and Reverend Eric, and also just for our being able to come forth in this, because we were all in this together, and being able to understand the need and everything that was taking place. Everything that, as you have said about the implementation and how it worked out with the faith leaders and for the churches, we started out with the training, and y'all made it so easy, for us, training for the CHL, being able to come. And when I'm saying training, I'm saying some rigorous training, and thank y'all for the food. But it was, it was some training in the mornings. If we couldn't be there in person, then we were able to do it by Zoom, but we were able to come together as to what our goal, and we were on, a mission, and we thank God that we would be able to be a part of the mission that we were on, and that was and still is in educating our community, our people on this COVID and what it was all about. The fact that we were able to bring it forth with your help, because of everything that you gave to us with the toolkit, that was given to us, and that we were able to implement, that had the like I said, that had the testimonies of folk, that had stories of folk that gave us, and this is something, because, when, and I'm just gonna say that when we received the sample order of service, and I said, okay, now we don't have, but it's what we needed. And now y'all have to see this sample order of service, for the kickoff and for the response kickoff, praise and worship, the prayer, and they know the churches, and then they had a divine message, and for that, and so to bring a message that was that had to do with COVID, and had to do with our being able to. Our church is about healing, and and not just spiritually but holistically, and so be able to do that, and they were right there when it came for the kickoff response. Dr. Jeanette's there. Carol is there. We were at this time able to be back in our churches. When we started this, we were not in our churches, but at the time that we were able to have the kickoff, we were back in our churches. So we were able to use everything, from the toolkits, as far as with the responsive reading. We were able to do this at our on our in the church, but it was also, since we were now on social media with our Facebook Live worship services on Sunday, Facebook Live, we were able to do that. We were able to use our audiovisual equipment and all of that. So then to be able, again, like I said, to have that responsive reading and to have persons to be able to do that, and not just one time, but we did it a couple of times for that, to be able to send out the information. And this was not information that we had to come up with, but it was information that was supplied. Everything that was sent, the flyers, all of that, everything that we were able to email, all the information that we were able to email, that was already developed and given to us to be able to do that. One of the things that I found out is, and I think we're all trying to understand this when it comes to with our African American community, and you have something like this, as far as okay, we're gonna try that, we're gonna do this, we're in a crisis here, and we want to be tested, and you think that everyone is trying to come forth and want to be tested. That's not so. Everyone was not trying to do that because of distrust. And I think we had talked something about it also, about information that was taken, gotten, research that was done, but we wanted them to know, that they were able to look back and think back on, well, no, we've been testing, they've done this before. How do we know that it's not trying to do something in the African American community? Remember Tuskegee, all those things like that. But what we did, of course, find out, and I'm thankful again when it comes to the faith community, is that when the leaders are able to come forth and to bring about a trust, bring about, okay, let's get some education on this. When the health liaisons, the ones that are working, and as they said, now you have those people in your the ones in your church that have that relationship with everyone else. They may they listen to the pastor, but they also listen to Sister so and so, and Sister so and so is going to talk, and she's going to talk not just those in the church, but she's talking to her family and talking to her friends, and I had I brought the right sisters, and they were working as far as when it was time for implementing of the testing. The departments, they came forth. We had a walkthrough. We were having it in our parking lot. They came forth early to walk through and see the logistics of it, and then we were able to set it up after church, so that right after church, I've already been talking to our folk. So right after church, they were able to go out and to head on out to be tested, and it was a smooth way of going about it. The other part about it had to do with the next time we were in testing, we had pre-registration, actually both times, but having pre-registration, the person's already registered, so your name is on for both times. Your name is there. Again, being able to have that, the fact that we're again working with our community, when it was not just our church, just our congregation, but members, that folk that were not a part of but a part of the community, but we have their relationship with them. And so that we were able to come forth, and when it was time for a survey, for them, have at a community, we have a community breakfast, and for them to be able to come and for the part of the community breakfast, and like I said again, about the the tracking, for after each event, to be able to come forth and, what worked, what can we do better? Did you have this, or did we have, and we're able to handle, send those in, again, also with the tracking. And I want to go back again also to our kickoff worship service, Dr. Jeanette being there, Carol being there, Dr. Jeanette coming forth to implement, to speak, to address the congregation about what was happening, what we were trying to do, and then also they left there and went on over to the parking lot. Also, another part they didn't talk about was they had, the faithful response to COVID had colors, at blue and white. Carol told them, can we get some balloons? So sure did. We went and got our balloons, had it all set up out there. They had some, signs and posters that we were able to go out and in the parking lot to be able to put those up, and even afterwards, by the next time that we were to do the second testing, right now the vaccinations have come forth, and but to be able to so to be able to explain to persons, and they already had that, reasons why you should be tested anyhow. And so the persons were able to come back, and were able to come forward and they said, I'm already tested. I said, no, we already sent this information out, gave them information why they should get tested anyhow, and to get tested, should get tested again. And so in this, I want to just bring forth with the collaboration. I know how it works in churches, and I know that it's not just persons, folk that are outside of the church, but persons that are inside the church, also that are members, of the faith community that have some trepidation, have some wonders, and once we're able to work with them and come together, then they were able to also go forth and again work with family members, co-workers, everyone to be able to do this. So we just want to thank God that as we continue with this collaboration, it has worked and it is working, and as we continue to go forth. So just grateful for this, and for all that is taking place in our community, and on this coming forward to be healthy on this east side in our community. Thank you.
Thank you. We can advance. Thank you, Reverend Allen.
You're welcome.
You preached a sermon for everybody today.
Yes, for sure.
Reverend Eric started it.
Well, we so appreciate the dedication to this project with our faith leaders across the city. And, it's really their dedication to this project, from being a part of it early on and having ownership for it, really progressing through those whole phases of helping us to conceptualize it and helping us to develop it, serving as interventionists, and helping to provide evaluation data that really contributes to the sustainability of this project. So we just, again, appreciate all of the dedication and commitment from our faith leaders. But along with that, we are looking at sustaining the project through also additional funding. Because of this work, because of our Faithful Response Project, our local county, Jackson County, saw all the media that was happening because of this project, and came to us and asked us to write a proposal to increase access to COVID-19 vaccinations as well. And so we received $5 million over a 6-month period to expand COVID-19 vaccinations throughout Kansas City's east side, even with many of the churches that are involved in the faithful response. And then we'll have additional opportunities for funding through our county as they receive their American Recovery Plan Act funds. And so we're looking forward to continuing this project with some of that funding. And also even through the sustainability of our partnerships. We've mentioned several times that our partnerships run long and deep, not only with our faith community, but also with our Kansas City, Missouri Health Department and other health agencies throughout Kansas City. And through those partnerships, we are always looking at ways that we can turn what we call our Cadillac, that's the grant funded, high level funded interventions, into Pintos that can run the distance as we embed them into the infrastructure of our existing partnerships. And then that also speaks to how we sustain our projects by continuing to engage our community throughout every phase of our research studies. Because of their engagement, again, they feel that ownership, they feel that commitment to carry on the project. Even when the grant project's in, many times they're coming to us to ask if we can replenish their toolkits, especially if they're doing a health fair or other health-focused events in their churches. And then I also have to say too, a part of our sustainability is even the engagement of our students. Through this project, we've been able to have over 50 students participate in some way from our School of Medicine, from our psychology department, in coming out and volunteering as a part of the COVID-19 testing events. And so through all of these different strategies, we are planning for sustainability in partnership with our faith community. Next slide, please. And so lastly, Reverend Eric Williams will talk about some of the emerging needs in Kansas City as it relates to COVID-19 and other issues.
Thank you, Dr. Patton and everyone else, Carol and Dr. Faith. Thanks for pushing it out there. So I see some of the questions in the chat, and I think there are some other folks on the call that are assessing faith leaders as well, and would like to involve churches and some of the things that you're doing. I'll just warn you that it's not everybody's cup of tea, and that there are many people that think that we should stick to evangelism and preaching rather than what they might consider social gospel. My response to that is that if we don't do this, then our pews become empty. Behind you, you see the stairs to our worship center. I guess there are about 18 stairs that we have to carry those caskets up. And on occasion, we had to open the doors or take one of the doors off because sometimes you had to buy those oversized caskets because of obesity and diabetes and all that. And it's not pleasant. But it's projects like these that I think that save lives and answers the question, where is the church? And so as you're recruiting, as you're talking to folks, as you're considering involving faith-based entities in your work, please remember that. Remember also that they're generalists. Pastors are generalists. They get called in on just about everything. And that's just another thing to be called into. And so your friendship and support and making it easy for us is highly appreciated. Words like equity and fairness and hesitancy and race always enter into the conversation, and they're real issues, and they're real needs, and the voices of people who are being ignored have to come to the top. We have to begin to listen to people. We have to allow folks to participate. How do you say it, Jeanette? Community
based, participatory, yeah, and all the rest of it. Say it real fast. It's allowing the community to speak for itself and to design things that it can use. It's emerging. It's emerging, and COVID's not. It's not going to be the last thing. I wish I had great news and say that there'd never be another pandemic, and there'd never be another problem, but that would be a lie. And so my prophetic voice tells you that we've got to get ready for the next thing, and developing leaders and developing trust now is what will help us in the future. We have the opportunity right now to partner for change. We can set policy. We can change the policies that include redlining. We can change the policies that make it hard for people to open grocery stores in disenfranchised areas. We can develop food policies in our churches so that we don't have the funeral and then go to the graveyard and then come back to the church and then eat what killed the person we just buried. There's so many things that we can do if we do like Pastor Faith said, and understand that we're all in this thing together. I think that's my time. I think that's my assignment, and I certainly appreciate what you're doing all over the country, all over the world. I think I saw Canada on the line as well. God bless each of you.
So this
Thank you so much.
really is just an acknowledgement of all of our partners across Kansas City, along with our co-investigators and our community action boards. And so we just want to give a shout out to them for all of the work that they do to make this a success.
Thank you so much, all of you. That was just such a rich presentation. And I know I learned a lot, and I have a lot on my mind that I'm thinking about. One thing that really stood out to me, Reverend Williams, that you said is that partnerships are like friendships. And that just really stood out to me because at CCPH, we do a lot of training around, how to build partnerships authentically. And I think that's a really
I remember
yeah.
I was doing a workshop at one time, and I said I compared them to marriages, and I got a lot of flack because there's some good ones and there's some bad and bad ones, and you got to do a lot to keep both of them in place. But I totally agree with you.
Yeah. Well, one of the reasons we wanted to host this webinar is because more and more academics and more communities are becoming curious about this concept of community-based participatory research and involving community members in the research process. So really this question is for any of you, but what kind of advice would you have for people who are just starting to dip their toes into this area, or starting to figure out, how do I do this? Where do I start?
Well, I can say for me that I started by serving. I was invited to, was told about an event that Calvary Community Outreach Network was doing years ago that focused on HIV, and I showed up and just said, where can I help? And sometimes that really means being humble and having humility in settings where we want to forge partnerships. And that means jumping in and serving and showing that you're really committed to the new partnership, and also willing to do some things that really don't have to do with research. And that goes back to Reverend Williams's comment on partnerships are like friendships. It's, in a similar way, in just trying to build trust between research and community partners.
Yeah, that trust building is so important. And it's another thing that we come back to again and again. And Reverend Allen, you mentioned, you kind of briefly referenced Tuskegee and the history of, violence and abuse, particularly against Black and African American people in this country, that's been associated with researchers. So, how do you kind of approach that concern among community members if people are thinking, they don't want to be involved in the research, or they don't trust researchers, because of that, that history?
Well, one of the things, and as I'm saying, with this whole thing of our collaboration, was we were able to have provide information, myths, debunking this and saying that, because of course, when I had persons as far as with vaccinations, but some, when we were having the testing, they didn't even want to get tested. And so you're able to have, they were able to give us information. I was able to send persons to those that were as part of the testing that would, they would come and say, well, I'm afraid. And I would, and I would say to them, well, I'll tell you what, go over there and go and just ask, ask the lady, ask the nurse, ask this person, about that. But to be able to have something that would go against, that would debunk all of the theories, and my good God, Lord, there's so many theories that are out there, folks that are getting things off of Facebook. And some of the reasons why they would come forth about, I'm not doing this because it does this, and it's going to do this. And, and you just have to just at that point, really just, speak truthfully to them, listen to them. I've learned not to just say, where do you get that? That's so crazy. I just learned to say, be able to have something to give to them that is, a reason and for that, and give information to them for that.
Yeah, thank you. I want to get to some of these great questions from our audience. One person is wondering about your most effective means of communication with the community, whether it was Zoom, flyers, in-person events, what works, or what worked in this case?
I think it was all of the above, because just the fact that we had started using, different ways and being virtual and different ways of worshiping and gathering together. So it was all of the above. We, are virtually, our emails, or being able to, with the flyers, we just walked, so we just walked the community and handing out flyers, and again, keep on going with the word of mouth. That's one thing that helps too.
Mm-hmm.
One thing that I'd like to add to that, Emily, too, is that before we even wrote this grant together with our faith partners' input, we had already begun talking with each other, particularly with our faith leaders, about how are you congregating now during a pandemic.
Mm-hmm. Mm-hmm.
It's totally different than what's been done historically. And so we learned from them that not only were many of them now to the technology world that hadn't used live streaming or Facebook or any of those approaches before. They were doing everything from having parking lot services to doing an each one, reach one, to recording their services and posting them on their websites. Mm-hmm. And so I think our churches really, quickly began to figure out how could they not only disseminate their church messages, but also this project as well.
Mm-hmm. Mm-hmm. We've got a couple questions about your funding. Now, of course, the RADx-UP project is funded by NIH, but did you identify any supplemental funding sources, like from the local health department, or, how do you find funding?
So yes, for this project, it's certainly being funded through the RADx initiative. However, we've been doing faith-based research for a number of years here. So we've had NIH funding that's focused on HIV testing in African-American churches. We currently have a study that's looking at diabetes prevention with African-Americans through a safety net hospital. And we also have received funding through our county to address COVID-19 vaccinations. In addition to that, another one of our funders for some of our faith-based work has been our local foundation. And so I would strongly encourage others who are looking for funding, whether it's for this project or other COVID-related projects, to look at those sources, those local foundations, through their governmental sources. This is a unique time where a lot of our governments are trying to figure out how to partner with, not the usual suspects to expand access to not only COVID-19 testing, but to vaccinations as well.
Thank you. So we're almost out of time, but I think we'll have time for one more question. So there's a couple questions related to if you have advice for ministries that are small and may not have a large staff, how to launch these kinds of projects. And also, if it's an organization that I guess, so one of the questions is, oftentimes these partnerships begin with the academics approaching community and faith-based organizations. But if there were, a smaller church who wanted to become engaged in a research project, how would you recommend that they approach academics to get involved?
Let me try that one on for size. Our church is probably the same size as Joel Osteen's church. Just kidding. We would be considered as a small congregation as well. But a lot of the things that we do in community are fueled by these types of programs. The other thing is to researchers or grantees that are holding the purse strings, and let me just say it this way: please release funds to the people within the community. That's one thing that has been so fair, that Dr. Patton and her staff understands that some of the money should be left in the community, and that we shouldn't be left holding the bag and doing everything without getting compensated for it. So that definitely helps. I think it gives ministries and volunteers some things to do. There's one comedian said, I love Jesus. I just can't stand some of those folks that work for him. And so if we would arm people with things to do and give them training, give them ample roles, it really helps. Give your parishioners other tasks to perform, so that they don't have to meddle.
Wonderful, thank you.
I better shut up.
Yeah, I wish we had more time, but please fill out our evaluation survey. We would love your feedback on this webinar. And please go to our website, ccphealth.org, sign up for our newsletter if you want to hear about other events. We're going to have a lot going on this year for our 25th anniversary, and a lot of great events like this one. Thank you again so much to all of our panelists. That was just such an amazing presentation, and thank you to the staff at CCPH for supporting this, to our partners at RADx-UP and the CDCC. Yeah, thank you all. And we will end.